The May 2022 MEC Minute is on eye trauma. This topic was suggested by one of our EMS coordinators after I requested they provide topics for these sessions. So I think eye trauma is a good topic. We have not covered it before. What we are going to talk about is we're going to talk about 7 eye injuries that you need to be aware of, or types of eye injuries. And as part of our conversation, we're going to also talk about some time-critical conditions where your actions make a difference, in which case you really need to be quickly involved in patient care, because what you do can salvage the patient's vision or prevent the worsening of their injury. So the injuries we're going to talk about are open globe injuries. We'll talk some about chemical injuries. We'll talk about foreign bodies of the eye. We'll talk about hyphema, which is blood in the anterior chamber of the eye. We'll talk about fractures of the orbit, particularly the infraorbital area or blowout fractures, and a little bit about corneal abrasions, which are a common reason for patients to present to the ED with eye complaints. And as part of the conversation, we'll talk about hospital management or pre-hospital management for EMS providers to give patients. If you look at my pictures, it kind of gives you an idea of what we're going to talk about. If we're looking at here, we've got a penetrating injury to the anterior part of the eye. Here we have a picture of a dark foreign body of the cornea, probably a piece of rust. But this is a common eye complaint for evaluation in the emergency department. And then you've got a gentleman who must have been outside doing something, and it looks like he's got a stick that goes into his upper eyelid, and you can see that the eyeball itself is being pushed downward. The guy looks in remarkably good shape for this type of an injury. I think I'd be on the ground screaming. But this kind of gives you a sense of what we're going to be talking about. Before we, though, get too far into discussion about injuries, we need to talk a little bit about anatomy and assessment. So on the left-hand side, I have kind of a cross-section of an eyeball. Majority of what we are going to be concerned with is this front part of the eye, because that's what you can see in the field. So the front part, you've got the cornea here, which is the clear part of the eye. That's the part of the eye that you would rest a contact lens on. You've got the iris, which is the muscle area of the eye that adjusts the size of the pupil. It will also help adjust the lens so that you can focus. So that we have the iris, the lens, and the pupil. And this area in front of the iris but behind the cornea is what we call the anterior chamber, and that is an important part of our assessment in the emergency department and in the field. Then you have the back part of the eye, which has got the vitreous in it. It's the clear jelly-like material that light is transmitted through. The lens will focus light onto the fovea and macula. That is the part of the eye that has the clearest of vision. That's where our clear vision comes from. When you're talking about peripheral vision, you're typically talking about light that is going to the part of the retina in the back that is not associated with the fovea. The fovea and the macula also is what gives us color vision, whereas the other parts of the retina tend to be more black and white. And then all the way in the back, we have the optic disc, the white spot at the back of the eye. That's where the optic nerve enters into the eye, and the nerves branch out into the retina. So how about our assessment? So when you have a patient with an eye injury, ABCs and scene safety come first. What other treatment priorities do you need to manage? If the patient is not breathing, it really doesn't matter what's going on with their eyeball. We have to get their breathing maintained. If they're actively bleeding, we need to control the hemorrhage. So think about other injuries that need to be treated. We also need to know what's the mechanism of injury. What happened to the patient as a result of the eye injury? Were they hammering a nail with a hammer, and now they have a pain and foreign body sensation in the eye? Did they get a splash of a chemical in the eye? If so, what chemical was it? What symptoms might they have? Do they have pain? Do they have vision change? Do they have tearing? Do they have all of the above? So, what do they have? Do they have sensation of foreign body? And then take a look at the patient. Look at the eyelids. Look or palpate the bony orbit. It's the bony orbit that protects the eyeball from injury, and often the eyeball is protected, but the orbit takes the hit, and they have a facial fracture, which could be more easily managed than if they actually had injury to the eyeball. Is there any evidence of tearing or redness of the eye? If they're tearing, is it clear? Is it cloudy? What does the anterior chamber look like? Remember I said, that's one thing we can see. Is this anterior chamber clear? Is it cloudy? Is it bloody? What's going on? What does the pupil look like? Is it round like it's supposed to be? Does it respond to light? Does it look asymmetrical, meaning does it look like a teardrop instead? Can you see any obvious foreign body? And then what is the patient's vision? Vision in a patient with an eye complaint is considered a vital sign. So do your best to get some measure of the patient's vision. I have the eye chart posted here. It's not that I expect everybody to take out an eye chart, put it on the side of the truck, and get the patient's vision at 20 feet. But we should have some assessment of their vision. Is it normal? Is it blurry? Can they see light? Can they see your fingers? If they can see your fingers, at what distance from the eye can they see your fingers? 1 foot, 2 foot, 5 feet. Can they count fingers? Can they see motion? If they can't see the fingers, can they see motion or can they see light? So it's some measure of their visual acuity. And then what treatment was provided for the patient prior to arrival? Particularly if there's a chemical injury to the eye, was the eye irrigated? The first up for us is going to be open globe injuries. And these injuries that are open, meaning there's a tear or some penetration of the eyeball. Is it blunt or penetrating? Did they take a fist to the eye and now the eye is ruptured? Or do they have some obvious evidence of penetration? What does the pupil look like? Again, is it round? Is it reactive? Is it teardrop? Do they have evidence of an acute cataract? Meaning, is the lens clear or is it cloudy? It doesn't look white. So if the lens has a penetrating injury, it tends to immediately turn to cataract. So it goes from being clear and the patient can see through it to it's now cloudy and white and they can't see through it. Is the eyeball injected? Is there any evidence of a scleral tear? The sclera is the white part of the eye. Or is any evidence of rupture? So starting with some pictures, here's a patient, they have a globe injury, and if you look at it, the pupil is not symmetrical, it's not round, and you have this little bulge here. So this suggests that there's a tear on the edge of the cornea here, and some of the fluid from the anterior chamber is extravasating through that hole, and it's taking some of the iris and some of the pupil with it. This is not a good thing. How about this one? So here you have an eye, and you see this big white thing sitting here. Well, that's a traumatic cataract. So it went from being a clear lens to now a cloudy lens because there was penetration through the eye. It hit the contact or hit the lens, and it developed a cataract. The other thing about this is it looks like the lens, because of the injury, has been displaced and is now anterior or in front of the iris. So there's been a significant injury here. Here's another picture. This one suggests that there is injury to the sclera or the white part of the eye. If you look at this left picture, you can see again that there must be a tear along the edge of the cornea. The iris, which is this material here, is protruding through that laceration or tear, and it's pulling the pupil toward it, and the pupil is asymmetrical and is also abnormal. And then if you look at this picture here, you can see that there's a tear of the sclera, and you see dark behind it, which is actually the inner chamber of the eyeball. So you're seeing the vitreous right here. So this is evidence of a scleral injury, probably either from penetrating event or from globe rupture. And finally, here's an eye that has ruptured. So if you look at it, this looks like they're in the OR. This is probably a small suction device, but you've got air bubbles in the anterior chamber. The pupil is wildly distorted. It looks like there may be an iris laceration here. There's a laceration of the sclera down here, and it looks like they put a couple small stitches in it already. And this is some of the vitreous protruding through it. Not a good problem. So what do we do for open globe injuries? Well, we need to avoid increasing intraocular pressure. Anything we do or the patient does to increase intraocular pressure can exacerbate the wound, cause more protrusion of eye materials. So we want to avoid putting any pressure on the eye. If you need to feel the bony orbit to see if it's fractured, that's okay, but don't go touching the eye. We need to do other things such as controlling nausea and vomiting or telling the patient not to Valsalva, because those are things that can increase the intraocular pressure, which aggravates the injury. So if they're vomiting, get an IV started, get them some Zofran. You can use an eye shield as long as it does not put pressure on the eye. Do not use an eye patch. So really, the eye shield is meant to shield the eye. It doesn't put pressure on the eyeball, whereas an eye patch will put pressure on the globe or the eyeball. So eye patches, really, for anything we talk about today, should not be considered as treatments. And then elevate the head of the bed to 30 degrees or so. That'll help reduce some of that intraocular pressure. How about chemical burns? Well, which is worse? Not that neither of these are good options. Acid or alkali? Well, acids tend to coagulate the superficial layers of the eye or the skin, whatever it comes in contact with, and that coagulation prevents further penetration by the acid. Whereas alkalis just continue to leach through the substance of the tissue, and so alkali burn to the eye tends to be worse because it just continues to penetrate into the deeper layers of the eyeball. Acids tend to be things like toilet bowl cleaners, bleach, vinegar, polishes. Hydrogen fluoride or hydrofluoric acid is a acid, but it's really in the ultimate of the bad boy club. It is very acidic, very damaging. It continues to penetrating through tissues and causes a lot of pain. We commonly see hydrofluoric acid used as a glass polisher or a glass etcher, and it's often used in rust removal materials that you might find in a body shop. Alkalis are things like lime, mortar, lye, ammonia. It's also in dishwasher detergents, which is why we don't like people to chew on the dishwasher tablets or pods. So what do we do for chemical burns? We start irrigation and we don't stop, particularly if it's a known acid or alkali. I've had patients who take a topical medicine like a foot fungus solution and they put it in their eye because they think it's an eye drop. Those solutions tend to be irritating, but they're not terribly dangerous. Whereas other foot solutions like wart removers are acids, that could be dangerous. So anything that's an acid or alkali, start irrigation and start it quickly and don't stop. Continue the irrigation while you're en route. If you find that the irrigation is irritating to the patient or causes pain, you could add some lidocaine, your IV lidocaine for intraosseous use or for cardiac arrhythmias can be added directly to some saline and use that to irrigate the eye. And if the patient needs pain medication, you can give them fentanyl or ketamine based on the pain protocol. How do we administer the solution? On the left, I've got a picture where you can use O2 cannulas. You put it over the bridge of the nose and you just start irrigating. We also have in our protocol the Morgan lens, and the Morgan lens goes between the cornea and the eyelids, and you use that to irrigate. Here's another picture how you put it in, and you can just continue to irrigate. There are some procedure photos in the protocol you can look at to get a better idea of how to place the Morgan lens. The other thing you need to do before you transport is identify the substance, because in the emergency department, we need to know what it is. Now, you can take a picture of the bottle, you can get a material safety data sheet, whatever it takes, identify the substance so we know how to treat the patient. The other thing you do not do is try to neutralize the substance. So we don't put bicarb in the solution if we want to treat an acid burn. It causes heat generation, and that thermal injury is even worse than just the acid burn by itself. So don't try to neutralize, irrigate, and dilute. How about foreign bodies? So when we talk about foreign bodies, you get some idea of, is this a superficial foreign body or is it penetrating? What was the mechanism of injury? Was high energy involved? Was the patient grinding on a grinder? If they were grinding, what were they grinding? Were they hammering a nail and something acutely went in their eye? And what happened? What was the mechanism of injury? So if you look at this CAT scan on the right, this is the right eyeball. It is normal. If you look at this left eyeball over here, you get this white spot. Well, that's a intraocular foreign body, meaning a foreign body within the eyeball itself. That needs to be managed. Probably it was a high velocity injury. So what is the mechanism of injury? High velocity, or were they walking through the shop and the wind came through and blew some dust in their eye? I mean, what happened to the patient? I have on here ultraviolet keratitis. It is not a foreign body, but it's foreign body sensation. Basically ultraviolet light generated by welders or by the sun, and guys or people are out in the snow without sunglasses, or people on tanning beds without corrective or protective lenses. They can get ultraviolet irritation of the cornea. It's very painful. It usually resolves with easy treatment over 24 to 36 hours, but it feels like there's a foreign body in the eye. Just threw that in there so you could get some perspective. I thought pictures speak 1,000 words. Here's some ideas. So this is a patient comes in complaining of a foreign body sensation. And as he was working on a grinder, you look at him, and yes, the eye is injected, but here is a foreign body on the eye, and it needs treatment. We'll probably numb up the eye. We'll take out the foreign body with a needle, and if there's a ring of rust left in the cornea, we have a small drill we can drill it out with. Here's another one: foreign body. The patient is complaining of eye irritation, and you flip the lid up, and here's a foreign body under the eyelid. Probably every time he or she blinked, it would cause pain. You'd also see this yellow material here. That's fluorescein. We use that as a stain. It is taken up by injured parts of the eye, or any corneal abrasions, and it will fluoresce yellowish green with a cobalt or blue light. And you can see right here there is some fluorescent on the cornea. So this foreign body was probably irritating the cornea. This is punctate keratosis. This is what we see with ultraviolet injuries. It's rather dramatic. This is fluorescein staining again. You can see the rim of fluorescein, and there's a blue light, and it all shines yellowish green. So this is ultraviolet keratitis. And then this is kind of an ultimate penetrating injury. You can see this needle sticking in the eye. What are you going to do about this? Foreign body treatment, check the vision. Again, it's a vital sign. Consider irrigation for non-penetrating wounds. Sometimes, if it's just some minor irritation from dust or something, you can irrigate the eye, see if it helps. You don't need to continue the irrigation during transport, but it may give the patient some symptom control. If you see some superficial foreign body of the eyelid and you have a Q-tip, you can try to remove it. If it's more than simple, stop. Don't make things worse. If there's a penetrating foreign body, you mobilize the foreign body if possible, particularly if it's large. You do not try to manipulate it. You do not try to take it out. Elevate the head of the bed 30 degrees. How about hyphema? Hyphema is generally due to blunt trauma of the eye. It results in tearing of the blood vessels of the iris, which then results in blood in the anterior chamber. Patients with sickle cell disease, however, are at risk for spontaneous or atraumatic hyphemas, so they can have blood in the anterior chamber without identified injury. About 80% of hyphema patients have other injuries, particularly to the orbit, because they've had blunt trauma to the area. And so always think about other associated injuries. These patients typically have some light sensitivity. They may have some pain because of the injury, and they tend to have vision loss because they have blood in the anterior chamber that prevents the light getting through to the lens so the patient can see what they're looking at. So here are a couple examples of hyphema. And if you look at the center picture, this is 100%. The whole anterior chamber is full of blood. Some people call this the 8-ball sign, so it looks dark and you see some light reflecting, so it looks like an 8-ball. This picture down here, you can see the hyphema in the anterior chamber. So it is layered out, and this probably involves about 20% of the anterior chamber. The other thing to notice is it looks like there's been a tear of the iris because the pupil is asymmetrical. So this is what hyphemas look like. How do we treat it? Well, we assess for other injuries, like I mentioned. Is there any evidence of injury to the face and so on? Elevate the head of the bed 30 degrees. What that does is allows the blood to start to settle. So this patient who's got this complete hyphema here, with 12 to 24 hours of just sitting or with the head elevated, this may settle down so that you see a blood level right here, but the upper part may be clear. We don't want to do anything that makes the bleeding worse, so no aspirin or ibuprofen in the field. About 5% of the patients with hyphema have to go to the OR. About 75% of patients who've had a traumatic hyphema eventually have visual acuity that's 20/50 or better. So the outcome is generally good if we treat these patients right. Some patients with hyphema can develop glaucoma as an acute complication. That's something that ophthalmology will monitor for as the patient recovers. A little bit about retrobulbar hematoma. That's a bruise behind the eyeball. It's usually due to blunt trauma. The blood behind the eyeball pushes the eyeball out, so the eyeball is pushing forward and it kind of bulges out. They often are associated with orbital fractures, but that's a good thing because with orbital fractures, the blood behind the eyeball can drain out into the nose or other places, which can decompress the orbit. That's a good thing. Symptoms tend to develop over hours. These patients tend to have a lot of pain. They tend to have decreased vision, and they tend to have a dilated pupil. And the patients with blunt trauma of the eye can often have either temporary or permanent paralysis of the ciliary muscles and the nerves that make the pupil get small, so the pupil can dilate just from blunt trauma. So if you see a dilated pupil in a patient with blunt trauma, be careful because there's something bad could be going on. Here's some pictures. If you look at this gentleman on the top, he's got swelling of the eyelids. He's got redness and swelling around the eyeball. This is a retrobulbar hematoma. It is pushing the eye outward. So how are we going to do this? How are we going to treat this? Well, we're going to try to do anything that reduces or prevents increasing intraocular pressure. So we need to control vomiting and avoid Valsalva maneuvers. Elevating the head of the bed is good because it keeps the head up. Gravity helps reduce some of that pressure, keeps the swelling down. We need to protect the globe. In the emergency department, we may do something called a lateral canthotomy. If you look at the eyeball from an anatomy perspective, here's the inner part. The nose is right here. This is the inner or medial canthus. This is the lateral canthus. If we do a lateral canthotomy, we can numb the area up. We take a scissor, and this sounds like a barbaric procedure, but it's relatively simple. But it is not an EMS procedure. It's an ED procedure. We make a cut in the outer corner of the eye. There's a muscle down here that we will cut through, and it kind of opens everything up. It relaxes the muscle in this area so that the pressure behind the eyeball is reduced. This can be a eye and vision saving procedure. It is very quick to do. I've only done a couple of them over the years. I don't ask for permission. I do it because I'm worried about loss of vision to the eye. So it can be a vision saving procedure. So this is what we call a lateral canthotomy. So what's wrong with this picture? This is a patient. Let's say this is a patient. You get called for a bar fight, injured person. You go evaluate the patient. You take a look at the eye. You notice the left eye is a little bloodied. And then you ask the patient to look up. Well, what do you see? Well, the right eye looks fine. Left eye, he can't look up. If you look at this picture as well, you'll see that he's got some bruising along the inferior aspect of the orbit. It looks like the pupil might be dilated, but I can't really compare it to this one over here. But if you ask this patient to look up, he can't do it. And if you ask him more questions, he'll tell you he's got some double vision. So what do you think he has? Well, I think he's got a blowout fracture. So we call it a blowout fracture because if you look at the anatomy of the eye and the eyeball, we have the bony orbit, we have the eyeball that sits in the socket, and if you look at the bone around here, the weakest part of the bone is this inferior edge between the socket of the eyeball and the maxillary sinus, or the sinus under your cheek. So if there is pressure applied on the eyeball, there's an opportunity for that pressure to be relieved by blowing out the socket and blowing some of the contents of the socket down into the maxillary sinus. So you look at this gentleman, he's got black and blue. If you examine him further, he may have diplopia. He may not be able to look up with this eye. If you feel along this rim here, he's got a lot of tenderness along the inferior orbital rim. If you get a CAT scan, on the left-hand side, it's normal. So here's the eyeball. Here is the maxillary sinus. These are the ethmoid and sphenoid sinuses. This is the bone that forms the inferior part of the eyeball. Look at the other side. Here's the eye. Here's the orbit. Go along. Oops, the bone's gone. And you've got, well, I think he's got a blowout fracture. So we call it a blowout fracture because if you look at the anatomy of the eye and the eyeball, we have the bony orbit. We have the eyeball that sits in the socket. And if you look at the bone around here, the weakest part of the bone is this inferior edge between the socket of the eyeball and the maxillary sinus, or the sinus under your cheek. So if there is pressure applied on the eyeball, there's an opportunity for that pressure to be relieved by blowing out the socket and blowing some of the contents of the socket down into the maxillary sinus. So you look at this gentleman, he's got black and blue. If you examine him further, he may have diplopia. He may not be able to look up with this eye. If you feel along this rim here, he's got a lot of tenderness along the inferior orbital rim. If you get a CAT scan, on the left-hand side, it's normal. So here's the eyeball. Here is the maxillary sinus. These are the ethmoid and sphenoid sinuses. This is the bone that forms the inferior part of the eyeball. Look at the other side. Here's the eye. Here's the orbit. Go along. Oops, the bone's gone. And you've got, so how are we going to treat this? We're going to assess for other injuries. We're going to provide pain control. We're going to elevate the head of the bed. Patients can be seen in the emergency department. We typically will get a CAT scan. If there's evidence of a fracture, we'll talk maxillofacial surgery. Patients may or may not require operative repair depending on the severity of their symptoms. It is not an emergency procedure. It's typically done as an outpatient via plastic surgery or maxillofacial surgery. Next up is corneal abrasion. This is a frequent reason to come to the emergency department. Typically, corneal abrasions are due to blunt trauma or from contact lenses. Some contact lenses, you can sleep in them, some you cannot. So sometimes patients will leave the contact lens in overnight. They wake up with eye pain and light sensitivity. And it's because they developed a corneal abrasion from this contact lens staying in. But it could be other things. Be aware of fingernails. Typically, we'll see patients who get corneal abrasions from fingernails, either theirs or from babies. It's amazing how many infants injure their parent by scratching the eye, and they come in with a corneal abrasion. Another common cause of corneal abrasions is paper injuries. Somehow a piece of paper is gets up into the eye and causes an abrasion. The cornea is exquisitely sensitive to pain. So if there's corneal injury, patients typically have exquisite pain. They may have a foreign body sensation just because there's corneal injury. The cornea doesn't know if it's due to an abrasion or a foreign body. It just hurts. There tends to be tearing from the eye, tends to be clear. And if the corneal abrasion is big enough, they can have light sensitivity. If it's a big enough abrasion, it can cause spasm of the pupil muscle. Light will stimulate the pupil to get smaller. That aggravates pain. How do we treat these patients? Well, we tend to provide supportive care. For you in the field, it's supportive care. If you have reason to think there's a chemical involved, feel free to irrigate. You're not going to aggravate a corneal abrasion with gentle irrigation. In the emergency department, we will typically start them on an antibiotic ointment, which is soothing and also helps with healing. If they have light sensitivity, we'll put some dilating eye drops in that temporarily dilate the pupil for 24 to 36 hours, which will make their vision blurry, but it reduces their light sensitivity. And patients with significant corneal abrasions may also require oral pain medication. So that's my last picture slide in review. You will see patients with eye injuries. It is important that we determine the mechanism of injury and visual acuity. Those are important components of our patient assessment, as are looking for any other associated injuries. Acids or alkalis, irrigate early and continue irrigation during transport. If the patient has an acid or alkali injury, you should not discontinue irrigation. You should continue and use bag after bag of saline until you've reached the emergency department. Pretty much for all of our eye injuries, elevate the head of the bed. A couple of my corneal abrasion, not going to be aggravated either way, but it'd be reasonable to manage all eye injuries just by putting their heads up at least 30 degrees. Because if you have patients with significant injury, elevating the head of bed will reduce intraocular pressure, which is a good thing. Do what you can to avoid re-injury. Part of that is irrigating the caustics out of the eye, but you can also protect the eye. You can use an eye shield if necessary. We're all pickers. We all like to touch things. Keep the patient's hands away from the eye that's injured. So a shield is okay. An eye patch is not. So don't ever use, for what you do in the field, don't ever use an eye patch. And then for any significant globe injury, particularly if you're worried about a hyphema or a tear of the globe or rupture of the globe or penetrating injury, control vomiting and avoid the Valsalva maneuver. Those are things that can aggravate the injuries. So that's all I have. Thank you. Hopefully you've enjoyed my picture show. Again, here's my contact email. If you have any suggestions for future MEC Minutes, please feel free to reach out. If you have any questions about content from today, either send me an email or post the question on Basecamp. Thank you.